It's your first day at work, and a 32-year-old female pregnant woman presents to the emergency room with vaginal bleeding. She denies having any contractions or having any abdominal pain. On examination, her vitals are stable and the fetal heart rate is reassuring. What are you going to do next? And what will be your most likely diagnosis? In this video, I will take you through antepartum hemorrhage, knowing that antepartum hemorrhage is an emergency until you prove that it's not. You will learn how to identify antepartum hemorrhage, the different differentials, and there's different signs and symptoms that we look for, and how you can manage a patient, so that if you're given the scenario that you just had, you will be able to help the patient. If you're ready, we can continue. So in the case scenario that we looked at, we saw that a female 32 years old who presents at the emergency room with vaginal bleeding. So if a patient who is pregnant presents with pervaginal bleeding, what are some of the things that you will do to help you, number one, come up with a diagnosis and be able to manage that patient? So your very next best step that you should take is you take a relevant history. So you want to do relevant history taking. And the most important question that you will ask to help you, because this patient has come with vaginal bleeding, we want to know where it's coming from. We want to know the cause of this vaginal bleeding. And so the first question that you need to find out is the LMP. When was the last normal menstrual period? Why is that important? Because the LMP will help you know whether this pregnancy or this bleeding is before the age of viability or this bleeding is after the age of viability. Now, if it is before the age of viability, and remember, as we discussed, age of viability differs based on where you are practicing. As we've mentioned, in America, it's about 20 weeks. In the UK, it's 24 weeks. In other countries like Zambia, where I'm from, it's 28 weeks, 26 to 28 weeks. So this is the age at which, if the fetus was to be extracted from the uterus, that fetus will be able to survive on its own. And so if it's after the age of viability, then it's antepartum hemorrhage. So the bleeding is occurring after the age of viability, but before birth, it's antepartum hemorrhage. And so what are some of the causes of antepartum hemorrhage? The question that is happening in your mind, okay, fine, this lady is, beyond the age of viability. This is antepartum hemorrhage. So then where possibly is the bleeding coming from? So these are the differentials that we're going to be using even as we go through and as we are discussing PV bleeding in pregnancy after the age of viability. So number one, we can classify them into four. So we have placental causes, and under placental causes we can be a placenta previa. So this is where there's a low-lying placenta, and this means that the placenta is in the lower third. Okay, it's in the lower segment of the uterus. We have a placenta abruption or abruptio placentae. This is when there's a premature detachment of the placenta. We have vasa previa. This is where there's a premature detachment of the umbilical cord, okay, or the umbilical cord is snipped or cut. That's vasa previa. Then we have uterine causes. One of the uterine causes that can cause PV bleeding in pregnancy after the age of viability is uterine rupture. Then we have cervical causes. In the cervical causes, we have cervical ectopic, we have cervical polyp, and cervical carcinoma. Then we have vaginal causes. Okay, Under vaginal causes, we have vaginal trauma, vaginitis, okay, infection in the vagina, and we also have other causes. Under the other causes, this is where we talk about coagulopathies, okay, like DIC, okay. We have other things here like non-obstetric bleeds, such as hemorrhoids, varices. So this is not directly related to the pregnancy, but maybe it's coexisting with the pregnancy, and so that's the one which is causing the bleeding. And also we can have heavy shock. So you may think it's a pathology, but maybe the lady has just entered labor and that is shock. Sometimes shock is heavy, you can think it's PV bleeding. And what I've noticed is that most of the patients that come to our hospital with a complaint of PV bleeding, most of the time it's heavy shock from my experience. And so now that you have all these in your mind, it can be a placenta previa, it can be abruption, it can be vasa previa, it can be uterine rupture. You know, some are more urgent than others. What is going to be your next step? What do? We continue with questioning. So your next most important question is, when does the bleeding start, or when did the bleeding start, and how much blood loss has occurred? So that's your next best question. When did the bleeding occur? So the duration of the bleeding is very important. It will help you to know what to expect when it comes to hemodynamic stability of the patient. Okay, if the patient has been bleeding and they've soaked 8 pads, and we know that one pad is about 80 mils, and you know that they have bled, and let's say they've been bleeding for 3 days before they came to the hospital, you are expecting that the hemodynamic stability might not be that good. So it will help you prepare and to also triage whether this is an emergency or it's not an emergency. Okay, so duration is very important. When you ask how the bleeding started, the patient can tell you it was of sudden onset and it was heavy. So usually if it is sudden onset and heavy, it suggests of a placenta previa or a vasa previa. On the other hand, if it's abruption placentae, it's more gradual, but it's increasing. Okay, it's more gradual, but it's increasing. Okay, sometimes it's hidden. Sometimes the patient may not even know that they are bleeding. Okay, so that can be a manifestation of placenta previa when it comes to how the bleeding started and when the bleeding started. Also, if there's minimal spotting, this could be suggestive of cervical ectopic or a polyp. So now that we know how the bleeding started, we can also find out from our patient, is the bleeding associated with pain or contractions? This is very important. When it's placenta previa or vasa previa, usually the patient is going to present with painless vaginal bleeding. So the patient will tell you the vaginal bleeding is painless. If it's abruption placenta or a uterine rupture, the patient is going to complain of severe abdominal pain, okay? And this pain is unrelieved, okay? It's continuous. So it's different. If somebody has a contraction, there is pain, and then when the contraction is done, there is no pain. But then in this case, because of the nature of placenta previa and uterine rupture, the patient is going to have pain consistently and it's going to be severe. Another thing that we are going to look at is the lower abdominal pain and backache. So the patient can present with lower abdominal pain and backache with mild contractions, and the difference between this pain and the pain in abruption placenta, here we're saying the pain reduces whenever the contraction stops. Okay, this can be suggestive of a heavy shock, especially if the patient describes the blood to be slippery or mucoid. Okay. The next best question that you want to find out, okay, is the color of the blood. Is the blood bright red or dark red? So bright red blood, okay, is suggestive of placenta previa or vasa previa. as the bleeding originates from fresh arterial sources, okay, which are close to the cervix. So the blood is going to be bright red. Okay. On the other hand, dark red is pointing more towards abruption placenta. Okay, because here the blood is from the veins. Okay, it's venous blood, and it may also contain. It may also be retained in the uterus before it's finally expelled. So it's more on the darker side. It can contain clots. Okay, so it can be mixed blood with clots. Okay, and it's pointing more towards placenta abruption. If the blood is mucopurulent or it is streaked with blood, so you find that this is discharge, maybe foul smelling, and there are streaks of blood. The patient will still think it's just the patient is just bleeding. Okay, but it may be pointing more to a vaginitis or a cervical ectopic. Okay, so now that we've asked the patient that question, what else are we going to find out? You also want to find out, has the patient experienced any trauma or any injury to the abdomen? Okay, trauma is a risk factor which can precipitate placenta abruption or previa or uterine rupture, pardon me. Trauma is less likely to affect conditions like placenta previa and vasa previa. You also want to find out if the patient has recently undergone a vaginal examination or has intercourse. Okay, if there's bleeding, contact bleeding, if there's contact bleeding, especially after intercourse or an examination, we are thinking that it's more towards cervical ectopion, cervical polyp, or placenta previa. This is less likely when it comes to placenta abruption and uterine rupture. So we want to find out, did the patient get injured in any way? That's the next question. Another question that you'd like to find out is to determine the hemodynamic stability of the patient. So you want to find out if your patient is experiencing dizziness, weakness, or fainting, which can show that there's been a significant loss of blood, okay, which is causing hemodynamic instability and pointing towards placenta abruption, placenta previa, or vasa previa. Okay, the milder cases like cervical polyps are less likely to cause symptomatic systemic symptoms. Okay, so it's very important to find out when it comes to your history of presenting complaint as you review the system in the history of presenting complaint. These are some of the questions that you can ask. We'll continue again on the history of presenting complaint. You want to find out if the patient is feeling the baby moving. Okay, are there any fetal movements that your patient can perceive? Decreased fetal movement may indicate placenta abruption or vasa previa with fetal distress or compromise. Okay, normal movements may may point more towards placenta previa. It doesn't rule it out, but it can point more towards placenta previa. So, in your antenatal history, what would be a relevant question that you want to find out? So, you would like to find out from the patient if they were diagnosed with any challenge, okay, when it comes to the placenta position during pregnancy. So you want to find out the previous scans. If possible, look at the previous scans and see if there was any comment that was made about the placenta. A non-low-lying placenta supports a diagnosis of placenta previa. The absence of such imaging does not rule it out. It still remains as a differential. When it comes to obstetric history, what are some of the relevant questions that you want to find out? You would like to find out, does your patient have a history of any similar bleeding episodes in the previous pregnancies? It's very important. In medicine or in obs and gyn, if it has happened before, the chances of it happening again are higher. If the patient has had placenta previa in the past, the chances of them having it are higher. If your patient has had placenta abruption before, the chances are higher. So recurrency suggests more on placenta previa or placenta accreta. It's very important to find out. Trauma is less likely when it comes to placenta previa, even as we discussed this before. You also want to find out that in the past obstetric history, okay, in the other pregnancies, has your patient had hypertension? Has your patient been smoking? Has your patient had preeclampsia? These uh, conditions like hypertension, smoking, preeclampsia are strong risk factors for placenta abruption. So once you find them there, at least it's giving you more support for the diagnosis that you make in the end. When it comes to your past medical history, you want to find out some of the relevant questions that you ask is, does your patient have any history of uterine surgeries or cesarean sections? It's very important. A history of cesarean section increases the likelihood of placenta previa, placenta accreta, even uterine rupture. Okay, so it's very important to find out. Also, in the past medical history or the family history, you want to find out, is there any bleeding tendencies in the family? Okay, this may be suggestive of a coagulopathy. So, how do you summarize your history? Now, remember, once you're done taking your history, you want to make a summary, and in the summary, you are putting your positives and your negatives, okay, which is going to support your differential. So we're going to look at the three most important under each of our differentials. So what are some of the positives that we are looking for when it comes to placenta previa? If you find them, then it's pointing you more towards placenta previa. One, painless vaginal bleeding, which is bright red. Okay, painless vaginal bleeding, which is bright red. Bleeding after sex or exertion. Okay, contact bleeding is very important because the placenta is low lying. So if there's manipulation on the placenta, whether it's through a vaginal examination or intercourse, it can lead to PV bleeding. Then there are no uterine there's no uterine tenderness or contractions in placenta previa, so we're not expecting those. So that is an important negative. Okay, it's an important negative. When it comes to abruption placenta, we are looking at painful PV bleeding, which is dark red. Remember, we've already discussed why the blood is dark red. There's going to be abdominal pain. Okay, the patient is going to have abdominal pain, and there's decreased or no fetal movement. There is decreased or no fetal movement. There is decreased or no fetal movement. That is in abruption placenta. And vasa previa also presents with painless PV bleeding. Okay, these are the important positives. Painless PV bleeding with bright red blood. Usually, okay, the patient will give a history of draining. Okay, the patient will give a history of draining. That means there was an episode of draining. Okay, there's rupture of membrane, and then there's the vasa previa. There's the bleeding that started afterwards, which is painless and bright red. Okay, that's what differentiates it from placenta previa. When we look at the fetus, okay, if we monitor the fetal well-being, we'll find that the fetal heart is bradycardic. Okay, fetal heart is bradycardic, or the fetus is in distress. So the patient may report reduced fetal movement. Also, there's a history of an abnormal placenta. There's a history of an abnormal placenta during the pregnancy. Okay, there's a history of an abnormal placenta during the pregnancy. So here it can be things like a subcenturiate lobe. Okay, so this is a lobe which is away from the normal placenta. or there is the positioning of the umbilical cord. Okay, the position of the umbilical cord is not central. Is not central. These can be risk factors we can need to vasa previa. Then we have uterine rupture. Patient will present with severe abdominal pain, and your patient will be hemodynamically unstable because they're bleeding. The patient can also present with fetal bradycardia or distress. Again, they will give a history of reduced or no fetal movement that they are able to perceive. Okay, when you're summarizing and you think it's cervical ectopic, what the patient will present with is postcoital bleeding or spotting, painless PV bleeding which is minimal, the uterus and the fetus absolutely normal, no issues at all. If it's a cervical polyp, patient will still present with spotting or light bleeding, painless bleeding with a visible polyp on speculum examination. If it's vaginal trauma, there has to be a history of trauma or injury to the vagina, okay, whether it is through sex, whether it is when an examination was being done, somebody fell, somebody was attacked, okay. There's going to be painless localized bleeding, okay, so it's coming from a specific spot. And when we look at the fetal well-being, the uterus is normal and the fetus is normal as well. Then we have coagulopathy. So when it comes to coagulopathy, okay, what you are thinking about is a persistent or excessive bleeding. So this is a bleeding which is not aligning with the cause. Okay, it's not aligning with the cause. The bleeding is more than what you should expect. Okay, there is bruising. Okay, the patient also present with bruising, bleeding in other sites, and also a history of a bleeding disorder. So we've been able to do a proper history taking. What's the next best thing that we do? So we want to do our physical examination, and what we're looking for is specific features that are going to point us to specific conditions, our differentials. Okay, so what you want to do is your general examination and the vital signs. So under our general examination, what we're looking at is, the reason why we're doing this is to identify signs of hypovolemic or hypovolemia or shock if there has been significant blood loss. So we're looking for signs of hypovolemia or shock when we do our general examination. So cord clammy skin, okay, loss of consciousness or reduced levels of consciousness, diaphoresis, okay, your patient is sweating excessively, okay, these can be signs that the patient has bled significantly. Okay, we also want to assess for pallor, restlessness, and signs of any hemodynamic instability. Vital signs which are important, we want to look at the blood pressure, the pulse, respiratory rate, and oxygen saturation. Very important. Hypotension and tachycardia may be suggestive of significant blood loss, which is consistent with placenta previa or vasa previa, placenta abruption, and uterine rupture. We move on to our abdominal examination. On your abdominal examination, want to differentiate between painful causes and painless causes. So the painful causes are placenta abruption, uterine rupture, and the painless causes are placenta previa, vasa previa. So when we do our abdominal examination, we want to majorly differentiate those. And so you want to inspect for any distension, okay, palpate for tenderness, assess uterine tone and height of fundus. Height of fundus is very important. If there's awkward bleeding, you'll find that the the height of fundus will be more than, it will not correlate with the gestational age. Okay, even in uterine rupture, the height of fundus will not correlate with gestational age. And so we also want to check for contraction and rigidity as you do your palpation and as you do your abdominal examination. Okay, so what are some of the possible findings that you can find as you do your abdominal examination? So if it's placenta previa, then the abdomen is going to be soft and tender with normal uterine tone. If it's placenta abruption, the abdomen is going to be rigid, tender. It is described as being woody hard. Okay, it's an abdomen which is tense, and it is described as woody hard. There is hypertonicity, okay, of the uterus, and there is increased uterine contractions. All these you will find if it's placenta abruption. It's pointing you more towards placenta abruption. If it's a uterine rupture, you palpate fetal parts. Okay, if rupture occurs, okay, you palpate fetal parts with tenderness and absent uterine tone. So that's the difference between abruption and rupture. One has hypertonicity, the other one has no uterine tone whatsoever. We'll continue and do our fetal assessment, okay, through listening using an auscultation tool like a fetoscope or a Doppler. Okay, what we want to assess is the fetal well-being and to identify whether there's any distress or bradycardia. So you want to auscultate your for fetal heart rate using a Doppler or fetoscope, and if it's vasa previa, as we mentioned before, there's going to be fetal bradycardia. This is due to the loss from the fetal vessels. So because the umbilical cord is cut or detached, you find that there's blood coming out from the fetal side. So there is bradycardia. Then if it's placenta abruption or uterine rupture, there's going to be absent or abnormal fetal heart tones. Okay, absent or abnormal fetal heart tones. If it's placenta previa, typically it's going to be a normal fetal heart rate unless the bleeding has been severe. On speculum examination, okay, you want to insert your speculum now. You can only insert your speculum after you have done your ultrasound scan. It's very important because you need to rule out placenta previa, because remember, placenta previa, the bleeding can be triggered by manipulation of the cervix. So while you're putting your speculum, you can disturb the cervix and you end up causing bleeding. So to prevent that, you do the scan first and then you do a speculum examination. On your speculum examination, another important thing that you should avoid, okay, is a digital vaginal examination. You do not do a VE until after placenta previa has been ruled out. So the purpose is to identify the lower genital tract causes such as cervical ectopic, polyp, cervical carcinoma, vaginal trauma, okay, and things like that. And so if there's placenta previa, you will see bright red blood pooling in the vagina with no identifiable cervical sources. So if you look around, there's no anything suggestive of a carcinoma, anything suggestive of ectopic, no polyps, no vaginal trauma, there's pooling of bright red blood, you're thinking this is placenta previa. If it's a polyp or ectopic, you will see visible lesions, or with cervix which is friable, okay, friable tissue which is bleeding, it points you more towards the polyp or ectopic. You may actually see a growth, okay, a pedunculated growth which may point you toward a polyp. If there is vaginal trauma, you will see visible lacerations, you will see hematomas, okay, which will point you that there was some form of injury which has caused this bleeding. So how then do you summarize your physical findings? What are the important positives and the important negatives? If it's placenta previa, again, we say there's going to be bright red blood, okay, from the vagina. So you may see it on the pad or during your speculum examination. The abdomen is soft and tender, okay, uterus. with a high presenting part. Okay, when you do your palpation, the presenting part is high because the the placenta is in the lower segment, so usually the head is not engaged. Abruption placentae, you will find a tender, rigid uterus which is woody hard, dark red blood, okay, whether on speculum or on the pad. There's fetal bradycardia or absent heart tones. So it's either there's no fetal heart, okay, or there's fetal bradycardia. If it's vasa previa, patient is going to come with red blood, but with a history of rupture of membranes. So there's going to be a history of rupture of membranes, or when you do a speculum, you will see pooling of both the bright red blood and liquor. Okay. Then fetal heart is bradycardic, okay, or in distress. The fetus is in distress. No uterine tone, and there is tenderness, okay, and or normal uterine tone, and there is no tenderness in vasa previa. In uterine rupture, okay, you palpate the fetal parts, okay. Again, this is because the uterus is ruptured, so you find that some of the fetal parts are in the abdomen, so you easily palpate the fetal parts. There is loss of uterine contour, okay, the uterus it loses its proper structure, and there's absent fetal heart sounds. These are the important positives and the important negatives. If it's cervical ectopion, it's going to be friable cervical tissue, bright red spotting with normal uterine findings. If it's a cervical polyp, there's going to be a visible cervical mass on speculum. PV bleeding, okay, after manipulation. So whether you after inserting the speculum or you do your VE, you'll find that there's going to be bleeding, which is secondary to manipulation. Okay. Then there is normal uterine findings. If it's vaginal trauma, you're going to see visible lacerations or hematomas, bright red blood with normal uterine and fetus findings. Lastly, if it's a coagulopathy, you're going to see persistent PV or persistent bleeding, okay, despite treatment. So even after giving medication, the bleeding does not stop. There's bruising and petechiae on different parts of the body, but the uterine and the fetal findings are normal. So now that you're done with this part of your investigation, what's the next part? So the next is you want to do your investigations, okay? What will you do so that you can clinch the diagnosis of, any of the differentials that we've discussed? So first and foremost, we want to do our ultrasound scan, okay? Whether it's transabdominal or transvaginal, more on the transabdominal. Why? Because again, we do not want to cause PV bleeding, okay? If it's a placenta previa or any of the cervical or lower tract, causes. So the goal will be to identify placental location, okay? We want to look at if there's any retroplacental hematoma and also the fetal well-being. So if it is a placenta previa, there's going to be the placenta which is covering or it's near the internal os, okay, based on the type. If it's placenta abruption, we're going to most likely see retroplacental clot or a hematoma, okay, whether it's resolving or it's active. Then if it's vasa previa, we will see fetal vessels which are crossing the internal os, It will point us more towards vasa previa. And if it's a uterine rupture, there is a disrupted uterine wall with possible fetal displacement. Okay, disrupted uterine wall with possible fetal displacement. Your next examination or investigation want to do our fetal heart monitoring, okay, using a CTG or a Doppler. In the image that you see there, that's a CTG, okay. So we want to assess the fetal well-being and to detect stress. So if it's a placenta previa, as we mentioned before, it's going to be normal fetal heart rate unless the bleeding was severe. If it's placenta abruption, there's going to be late decelerations on your CTG tracing, which is indicating of fetal hypoxia because there is less blood going to the fetus, therefore there's less oxygen going to the fetus. If it's vasa previa, there's going to be severe bradycardia. It's going to be severe bradycardia or fetal demise, okay, because the fetus can have a coagulation. The fetus can lose all the blood because in vasa previa the blood is coming from the fetus. Okay, our next examination that we do is want to do a complete blood count with blood grouping and cross matching. This is to assess the degree of anemia, estimate blood loss, and prepare for transfusion in severe cases. So a low HB or hematocrit will signify a significant blood loss. Elevated white blood cells, okay, will signify an infection or an inflammatory process which is occurring. Remember, vaginitis or a chorioamnionitis can exacerbate bleeding. Okay, it can exacerbate bleeding. So once you notice that there are signs of severe blood loss, then you want to do your AB or RH to know the blood group and cross-match for blood transfusion immediately. Some more investigation that we do, want to do our clotting profile. Remember, this can be due to a coagulopathy. So want to detect coagulopathies, especially in severe hemorrhage, such as in placenta abruption, okay, or uterine rupture. Okay, because there's severe bleeding, we don't want to detect if the patient is in DIC. So there's going to be a prolonged clotting time, okay, in disseminated intravascular coagulation. So there's going to be prolonged clotting time, which is going to be more than 5 minutes. Then there will be no more results if it's a placenta previa or any of the cervical causes that we discussed. Another important investigation that we can do is fetal maternal hemorrhage testing. So this is to detect fetal red cells in the maternal circulation, okay, especially if there's trauma or if there's an abruption. So if it's positive, okay, it will point more towards an abruption or it will point more towards uterine rupture. Okay, an abruption or uterine rupture. So we'll see, we can see there, okay, when we do blood slide, we notice that we have the maternal ghost cells and the bright red are the fetal cells. Okay, once we do this test, so if there are more of the fetal or if there's presence of the fetal blood cells in the maternal blood, then it's pointing us more towards placenta abruption or uterine rupture. In very selected cases, okay, if ultrasound scan is not conclusive and we are suspecting maybe there's accreta of the placenta or uterine rupture, then we may want to do an MRI. And so this will give us a detailed visualization of the placenta, okay, invasion, and it also will show us a detailed visualization of the disruption of the uterus in the case of a uterine rupture. So what is the summary of our investigation? Okay, so the different investigations are uterine or ultrasound, speculum, CTG, okay, full blood count, clotting profile, and the fetal maternal hemorrhage test. So Let me just show all of them. Then we'll be looking at them horizontally. So an ultrasound scan, if it's a placenta previa, okay, it's going to be, the placenta is going to be near the os. If it's abruption, there's going to be retroplacental clot. If it's vasa previa, there's going to be fetal vessels on the os, internal os. If there's a uterine rupture, there's going to be disrupted uterine wall. If there's cervical cause, there's going to be a normal ultrasound scan. On speculum, if it's a previa, then there is no cervical lesion. Abruption, no significant findings. Vasa previa and uterine rupture, no significant findings. On cervical causes, we may find ectopion or a polyp on speculum. CTG or Doppler, if it's previa, then it's normal, unless, and those are in mild cases, unless in severe, then there will be fetal compromise. Abruption placenta, we see late decelerations. Vasa previa, we're going to see severe bradycardia. Okay, we've discussed because the blood is coming from the fetus, because of can lead to exsanguination of the fetus. Uterine rupture, there's absent heart tones. Okay, cervical causes normal CTG. When it comes to a full blood count, in previa, if there is severe loss of blood, there's going to be anemia. In abruption placenta, there's going to be features of anemia and DIC. Okay. In vasa previa, there's going to be signs of anemia if it is severe. In uterine rupture, there's going to be signs of anemia if there is massive loss. And in cervical and in the cervical causes, it's going to be normal. Okay, it's a normal full blood count. Coagulation profile for previa, it's normal. Abruption placenta, there's prolonged, the clotting time or the clotting profile is prolonged, same as in uterine rupture if there is massive blood loss. Otherwise, in vasa previa, in placenta previa, and in cervical causes, we have a normal coagulation profile. Lastly, in the fetal maternal hemorrhagic test, placenta previa is negative, abruption placenta is positive. Okay, fetal maternal fetal blood cells in the maternal blood. In vasa previa, if the fetal vessels have ruptured, then it's going to be positive. In uterine rupture, it's also positive. In cervical causes, it's negative. So now that we know how to recognize our different differentials, how do we manage patients? So what management plan are you going to formulate, which is going to help you help the patient? Okay, so here are the general principles or the general part of the plan that you're going to have in all the cases. Okay, number one, want to stabilize the patient regardless of the gestational age. So we do the ABC approach. Want to secure the airway, want to make sure that there's adequate breathing, maintain circulation, okay, with IV fluids, okay, with IV fluids and blood products if necessary. Okay, make sure that you cannulate your patient with 2 large bore cannula, and you continue to monitor the vitals. Monitoring is very important. So what we monitor is the fetal monitoring and maternal vitals. So we talked about how we monitor the fetus with the CTG, Doppler, okay, and the scan, and then we continuously monitor the vitals, okay, like the BP, the pulse. We continue to monitor the saturation and the respiratory rate. Also, we want to prepare for an emergency delivery. So from the time that the patient comes with previa bleeding, you want to begin to prepare in case preterm labor starts. In case we need to deliver this as an emergency, theater should be prepared, the personnel should be prepared. Okay. So now, how do you manage a patient whose gestational age is less than 34 weeks? Okay. So the differentials, of course, there's placenta previa, we have placenta abruption, we have vasa previa, uterine rupture, and cervical causes. So let's look at the different management plans and the reasons why. So if it's placenta previa, less than 34 weeks, but greater than the age of viability, want to admit the patient, observe and monitor for PV bleeding. Okay, observe and monitor for PV bleeding. Why? This is to ensure that there's no further bleeding and want to prevent complications. Okay. Additionally, want to give corticosteroids like betamethasone or dexamethasone, okay, for lung maturity, because in the event that there's premature delivery, want to prevent neonatal respiratory distress syndrome. We may also want to consider tocolytics. Okay, we may also want to consider tocolytics if there are contractions. Okay, if there are contractions, and there's no active bleeding, okay, we may want to consider tocolytics so that we stop the contractions, okay, and we prevent preterm labor. We prevent preterm labor. And the goal in this case is that we want to push the patient as far as we can. We can even go up to 37 weeks and we deliver the patient at term. Again, that's very important if there's no active bleeding. If it's placenta abruption, we want to stabilize the mother and want to monitor the fetus. Okay, so if SpO2 is low, want to give oxygen. If there is hemodynamic instability, when we look at the BP, want to give fluids, blood product. Okay, and monitor the fetus as we discussed using CTG, or want to use a Doppler. Okay, this is for us to prevent shock and to make sure that there's fetal well-being. Consider also giving corticosteroids because of possible preterm delivery, and then based on severity, we want to do an emergency delivery, okay, for the safety of both the mother and the fetuses. If there's any compromise to the mother or any compromise to the fetus, we want to deliver this woman, okay, so that we make sure that there's safety to both the mother and the fetus. Vasa previa, okay, vasa previa, remember there's nipping of the umbilical cord. So if not dealt with, this baby is going to bleed. Okay, we are risking, fetal mortality, and so we want to have an immediate cesarean section to make sure that we deliver that fetus. Okay, again, we would have given corticosteroids to improve lung maturity because there's going to be preterm delivery. If it's a uterine rupture, it's an immediate laparotomy with cesarean section. It's life-saving intervention both for the mother and the fetus, okay, and then we're going to repair, plus or minus hysterectomy based on whether we're able to correct the rupture or not. And then if there are cervical causes, okay, want to prevent infections and want to remove the polyp. Now this should be done if it's minimal, okay. We do not tamper with it if there's active bleeding, lest we exacerbate the bleeding, okay. And so the goal here is to prevent bleeding and is to prevent infection, but otherwise conservative management is the mainstay management for the other cervical causes until after we deliver the mother, or until after we deliver the fetus. If the gestational age is between 34 weeks to 37 weeks, okay, placenta previa want to admit for observation, okay, again we're looking out for further bleeding or complications, and want to plan for cesarean delivery at 36 to 37 weeks. Again, it's not all placenta previa types that we are going to cut and cut do a cesarean section on, okay. The minor, we can give the chance to the mother to deliver vaginally if it's minimal and there's no much vaginal bleeding. Otherwise, if it's major, then we would like to do a cesarean section, okay. It reduces the hemorrhage risk for the mother. So it's very important. If it's placenta abruption, want to do an emergency C-section to prevent fetal hypoxia and maternal complication. Okay, if it's above 34 weeks, no need to give corticosteroids. If the placenta abruption is mild, okay, there is chance for trial of SVD. There's chance for trial of SVD, but because we want to avoid unnecessary cesarean sections, okay. But if the risk is more on the mother and the fetus, then it's better to play it safe and we do a cesarean section. Vasa previa, there's immediate cesarean section should be done, again because of high risk of fetal mortality. Can be due to exsanguination. The fetus can lose the blood that they have. It's a uterine rupture, immediate laparotomy with a C-section, life-saving intervention for both, and we should prepare for plus or minus hysterectomy in the event that the rupture is, we're not able to correct the rupture. Cervical causes, conservative management, avoid unnecessary intervention. So if there's not much bleeding, there's no need to do anything. Okay, just conservative management is very important. Lastly, if the patient is above the age of 37 weeks, okay, the pregnancy, then we plan cesarean section. Okay, a planned cesarean section, if confirmed diagnosis, is very important. It minimizes maternal hemorrhage risk. So we need to sit down and plan how we're going to manage, or how we're going to deliver this particular woman. Okay. Emergency cesarean section, if there's active bleeding, is important. Okay, so we'll do an emergency cesarean section if there's active bleeding. This is to prevent maternal shock and fetal compromise. If there's abruption placenta, want to do immediate delivery. Okay, usually it's a cesarean section, but if bleeding has persisted and there's fetal distress, so this prevents stillbirths and maternal complications. Vasa previa, same management, immediate cesarean section, because we want to prevent fetal exsanguination. In uterine rupture, emergency laparotomy and delivery, okay, or with C-section is done, okay, done. This is to resolve maternal and fetal risks promptly. And lastly, if there are cervical causes, then treat the infection, address the lesions conservatively if there is no severe bleeding. If there is severe bleeding, don't tamper with them, because you can exacerbate the bleeding. So want to prevent progression of the bleeding and want to maintain the maternal health and the fetal health as well. So let's go back to the question that we had, but with a bit of a twist. I'd like you to comment in the chat what you would do based on what you've learned. If you're not able to answer this question, I encourage you to watch the video again, keep learning until you are able to answer this question properly, because who knows, it may be you one day in the emergency room and a 32-year-old pregnant woman at 34 weeks gestational age presents to your emergency room with painless PV bleeding. She denies having any contractions or any abdominal pain. On examination, her vitals are stable and the fetal heart rate is reassuring. That means it's stable. What are the next steps in her management, and what would be your most likely diagnosis? So I'd like you to just comment in the chat what you think based on what you've learned, and I will comment the answer in the comment section. If you have enjoyed this video, I'd like you to subscribe for more content like this. Thank you so much for watching. Let's go and save lives. And there's a video that I did on premature rupture of membranes. I have tagged it right there. So it's important for you to watch so that you learn and you'll be able to help patients who come with premature rupture of membranes. God bless you.